Stigma is a big challenge that patients continuously to face in my country. It ranges from employment termination, denial of visas, and even family breakdown. And my story is a true testimony of this stigma. I attended the burial of my friend who died of hepatitis B. It was a very big, unique event because he was buried like someone who had died of Ebola. The family members never wanted to extend close to his corpse. Neither did they want to keep him around for some days. Only those who were putting on gloves were allowed to get closer to his body. This raised a lot of questions, but with no answers. But on the other hand, it helped me to dig and do some investigations and research about hepatitis B. 3 years later, I personally went and screened myself against hepatitis B. Basically, I wanted to know my status and have myself vaccinated. I was not sick, neither was I feeling any pains. Unfortunately, my results came when they are positive. I couldn't believe the results. I was in total shock after losing a colleague. At any time I used to, recall the way my friend was buried, I thought I was going to die the next days. So I started informing my colleagues about my friends about hepatitis B and my status. But also I realized that each time I told them, they shied away from, associating with me. But also I realized that some of my friends actually were living with hepatitis B and they knew their status. But they could pull me aside and tell me about their status and how they were not ready to disclose their status because of the stigma and discrimination associated if they would have told the community about their status. I thought in the beginning that my wife was the one who had infected me with hepatitis B because she comes from a region that has the highest prevalence in my country. We went together with my wife to the hospital only to find that my wife was negative. So my wife immediately took her vaccinations and completed all the series. However, I kept on wondering on what would be for my life the next day. As a young man, my wife promised me to offer me the support that I needed until I would carry on, and she was very supportive. I am speaking to using my personal experience and also becoming a voice for the patients in my country so that they can have access to adequate information to bridge the gap of stigma, but also to make available the medicine that they require and also the diagnosis that is required in the monitoring of these patients. And I'm doing this through the National Organization for People Living with Hepatitis B, a patient-driven organization trying to amplify the voice of patients living with hepatitis B in Uganda.
So good afternoon, everyone, and congratulations for making to the final session of this inspiring World Hepatitis Summit 2017. My name is Francesco Marinucci. I work for the Foundation for Innovative New Diagnostics in Geneva. I'm here today to welcome you to the Innovation for Acceleration session, where we'll hear from our panel their experience in piloting and planning for innovative approaches to improve the treatment and care cascade for viral hepatitis in different settings. So in order to move on, in order to save time, let me hand over to my co-chair, Professor Joe Tucker from the University of North Carolina. Joe?
Thank you, Francesco. So I'd like to introduce Mr. Michael Ninberg. He's the Executive Director of the Hepatitis Education Project and the incoming president of the World Hepatitis Alliance. Mr. Nimberg has been a consultant to many governments and multinationals, and he's really a recognized leader in this field, a distinguished advocate, and a wonderful human being. So without further ado, Michael.
Thank you, Joe. I think you may have overdone it a bit there. I do think it's fitting that this penultimate session is about innovation. For patients, innovation is about hope. Hope for a cure, hope for access to treatment, hope for a life free from stigma or fear of progression to end-stage liver disease or premature death. For all of us, innovation is about inspiration. How can we improve the products, policies, and programs that we already have to get to elimination quicker? And very importantly, how can we accelerate innovation to meet the gaps that exist? In the past few years, we've seen amazing innovation in the hepatitis C treatment space. The first ever cures for a chronic viral infection. Think about that. Truly, it's a revolution in medicine, the first ever cures for a chronic viral infection. I was able to take advantage of one of those cures, one of the first protease inhibitors that was approved, telaprevir. For those of you who are familiar with telaprevir, it came with some innovative side effects as well, but I'm cured. And fortunately, innovation has brought us kinder and gentler treatments and cures for hepatitis C since that time. We've also seen recent advances in a number of areas. We've seen better point-of-care tests for hepatitis C. We've seen a vaccine for hepatitis E. And we've seen new non-invasive ways to assess liver disease. But there remain huge gaps. Of course, diagnostics, a cure for hepatitis B, treatment for hepatitis delta, and perhaps one day a vaccine for hepatitis C. We have seen innovative policies in testing, treatment, and cure. And this morning we heard about innovative ways to finance implementation of some of those policies. Finally, innovation in service delivery is going to be critical, especially for the hardest to reach populations. And we've heard a lot about the underserved and marginalized these past few days. But as we've seen with hepatitis C, having a cure is not enough. We have to come up with better ways to reach the most vulnerable and underserved in our communities. This includes people who use drugs, indigenous peoples, prisoners, immigrants and refugees. And whenever possible, we need to have representation from these impacted communities in the development and delivery of these programs. As we heard yesterday, very, I think, eloquently and potently, no decision about me without me. We are about to hear some truly novel approaches to some of our biggest challenges in getting to hepatitis elimination. Increasing the capacity of clinicians to treat hepatitis, and the race for a hepatitis B cure. Following, at the end of this session, we're going to hear from the 6 finalists . There we go. The 6 finalists of the World Hepatitis Summit Innovation Challenge. The finalists were chosen from 58 submissions for new and innovative ideas that will help us achieve our elimination goals. From micro-elimination projects in cities and villages to programs addressing stigma and the scale-up of treatment. These are the kinds of innovations in service delivery that we will need if we are going to get to no HEP. Get ready to be inspired.
Our next speaker is Professor Henry Cohen. He's the chair and director of the gastroenterology department at the National University of Uruguay. He's a former president of the World Gastroenterology Organization and a vice president of the National Academy of Medicine in Uruguay. And importantly, he's the director of the ECHO project. And today he's going to talk about ECHO. Professor Cohen.
Thank you, Joe. Good afternoon, everyone. I feel very honored to be here today to share our experience on using the ECHO model to expand access to care and treatment for viral hepatitis on behalf of my colleagues from the University of New Mexico, Carla Thornton and Sanjeev Arora, and myself from Uruguay. Here you have our conflict of interests. And the objectives of this talk are to describe Project ECHO creation, mission, goals, and activities, to introduce the basic principles and components of the ECHO model for education and workforce development, to highlight the existing and future global viral hepatitis ECHO activities, and finally, to share the Uruguayan experience. So, what is Project ECHO? It's an acronym that means Extension for Community Healthcare Outcomes. But it is important to know that ECHO is a model as well as a movement, and ECHO is a non-profit organization. What is our mission? It is to democratize medical knowledge and get best practice care to underserved people all over the world. And our goals are to develop capacity to safely and effectively treat HCV in all areas of New Mexico and to monitor outcomes. That was our goal at the very beginning. And also to develop a model to treat complex diseases in rural locations and developing countries. So what are the methods that we have in ECHO? We use technology to leverage scarce healthcare resources for the specialty knowledge and expertise. We share best practices to reduce disparities by reducing variation in care. We incentive case-based learning, that is learning by doing, to master complexity. And finally, we use web-based database to monitor outcomes. And how does ECHO work? ECHO links expert specialist teams at an academic hub with primary care clinicians in local community that we call them the spokes. Together, they participate in weekly tele-ECHO clinics, which are like virtual grand rounds, combined with mentoring and patient case presentations. The clinics only need to be supported by very basic, widely available teleconference technology. So here you see a diagram how ECHO works. We have the hub that are the ECHO facilitators, and they constitute a multidisciplinary team. And through ECHO, we get to the ECHO partners that are called the spokes, that are at the community level and the primary care team experience. Which are the steps we follow? First, we train physicians, nurses, pharmacists, and other teams. Then we conduct tele-ECHO clinics, that is what we call the knowledge network. Then we initiate the case-based guided practice, the learning loop, to which I will come back later. And we collect data and monitor outcomes centrally. Here you see in this picture Dr. Arora and his team managing an hepatitis C clinic in New Mexico. And here you can see that there are many centers in the small cities or rural areas that are connected to discuss their cases. And sometimes you can see in the right screen that a short didactic, no more than 10 minutes, is presented to update theoretical problems. So I told you about the learning loop. We try to build an interactive learning environment, and then we are able to co-manage cases, to learn by doing, to learn from didactics, to learn from each other, and finally, we can, in collaboration, solve problems. Which are the benefits to clinicians and teams? There is no cost continuing education credits. There is a professional interaction with colleagues with similar interests that leads to less isolation with improved recruitment and retention, and a mix of work and learning that is very difficult to get nowadays. and also a very easy access to consultation with specialists. But there are also very important benefits to the communities, as it is the increased access to treatment, the decreased related morbidity and mortality, and the training of the local workforce. What is the difference with telemedicine? That is a very important point. ECHO does not take direct care of the patients by teleconference because that is not conducive to demonopolizing knowledge and multiplying the number of patient cares. The repetition of this methodology and the mutual teaching allow the rural healthcare providers to progressively specialize and be able to assist their own patient at their place of residence. So here you see the diagram, and you see in the lower part that the traditional medicine, one doctor takes care of one patient. And with the teleecho, we have a team that is the hub team that is in touch with many doctors that finally will get more patients reached with specialty knowledge and expertise. That is a multiplying force. So what happened in 2004 in New Mexico with hepatitis C? There were very few health providers and no specialists, more than 35,000 reported HCV cases and less than 5% treated, and there was a high rate of chronic liver disease and cirrhosis. At that time, the maybe good news were that something in between 45 and 70% of cases were curable, but the bad news is that most of them have severe side effects, and no primary care clinicians were treating HCV in the state of New Mexico. So this paper, published in the New England Journal of Medicine by Sanjeev Arora and his team in 2011, is a real landmark for ECHO. So it was a prospective cohort study with two different groups, the intervention group with 16 community-based clinics and 5 New Mexico Department of Corrections, and the control group that was the patient treated at the level of the University of New Mexico. And the principal endpoint was the sustained viral response that was no detectable virus 6 months after completion of treatment. And in this slide, you can see the results. And if you compare the access to minorities through this methodology, you will see a clear difference in favor of ECHO, with 68% of minorities being treated by the ECHO group against 49 at the University of New Mexico. And if you compare the SVR in all the genotypes, both groups show approximately the same values of good results. That means that in conclusion of this paper, that primary care clinicians deliver hepatitis C care under the aegis of Project ECHO that is as safe and effective as that given in a university clinic. And Project ECHO improves access to hepatitis C care for New Mexico minorities. So you see, in 2004, less than 100 patients were treated in a year, and now with Project ECHO, more than 1,000, and at the university level, now 250. So there is a big increase in only 12 years. So recently, this paper was published in Gastroenterology only last month in October. The United States Congress passed the ECHO Act in 2016, requiring the Department of Health and Human Services to investigate the model. A cost-effectiveness analysis to assess diagnosis and treatment of HCV infection in a primary care patient panel with and without the implementation of Project ECHO was performed. Markov models were used to simulate disease progression, quality of life, and life expectancy among individuals with HCV infection and for the general population. And the results show the incremental cost-effectiveness ratio of ECHO was around $10,000 per quality adjusted life year. And the budget impact analysis shows payers would have to invest an additional $340 million over a 5-year period to increase treatment by 4,500 patients per 1 million covered life. And in conclusion, Project ECHO is a cost-effective way to treat patients with HCV infection at scale using existing primary care providers. This approach could substantially reduce the burden of chronic HCV infection in the United States. But hepatitis C was only the beginning. How to choose other diseases? If they are common, if they have a complex management, if they have evolving treatment and medicine, a high societal impact, serious outcomes if the disease is not treated, and on the other hand, improved outcomes if the disease management is correct. The current situation of ECHO is that we apply it in more than 50 centers in the United States and more than 20 countries all over the world. There are more than 1,000 clinics working with ECHO in all the world and more than 50 different diseases. You see here in this word cloud that hepatitis C is the biggest one, but there are also other important as chronic pain, autism, HIV, and many other diseases, more than 50, as I just said. In New Mexico, there are plenty of ECHO clinics, but in the United States also, the veteran system, Harvard University, Chicago, Washington, Wyoming, and many other universities are working with ECHO. And all over the world, you see in all the continents, from North America, where it began, South America, Europe, Africa, Asia, and Australia are already working with the ECHO model. So let's move a little to the viral hepatitis ECHO global activities. And here you see the map of the hubs that work in ECHO, and also you have in almost all the continents. And only a couple of examples that are very successful. The Georgia Hepatitis C Elimination Program that was started last year is now expanding all over the country. In India, there are many hubs, one directed by Professor Sarin, and this is only an example in Punjab, where they used ECHO to train staff at district hospitals and treated around 40,000 patients in only 18 months. This can happen only when HCV drugs are available at low cost. And in India, you can buy it for $250. So what about our experience? Uruguay is a very small country with only 3.5 million people, located just in the middle of two giants that are Argentina and Brazil. And we began there in 2014. It's a project of the National School of Medicine and the University of New Mexico with the participation of all the public and private health care institutions. 19 Uruguayan doctors and other health workers were trained already in Albuquerque, New Mexico, and now we run 11 ECHO clinics in the country, hepatitis C and HIV, adults and children palliative care, anemia, heart failure, cervical cancer, autism, autoimmune diseases, family medicine, and neurological rehabilitation. In 2014, thanks to the participation of the US Ambassador, Julissa Reynoso, we were able to bring Dr. Arora to Uruguay, and he was received by then President Mujica. Maybe you heard about him. He was chosen the best president in the world some years ago by The Economist, and he accepted, he liked ECHO, and we began immediately after that. And our current president, Vasquez, who is a professor of oncology, or was professor of oncology at the same university where I work, declared it of national interest last year. Uruguay had important international influence, and we helped to launch similar projects in Argentina, Brazil, Ecuador, Venezuela, Mexico, and Australia. In January last year, we were appointed as a super hub, and it is now a center of reference in Latin America and can train people from other countries. And new this year, we began to implement a palliative care project in Mexico, and we are training more than 350 people in Mexico City and other cities to begin ECHO in palliative care. So, ECHO is about building bridges between the university, the public sector, the private sector, and the community. ECHO is about force multiplication between specialists, primary care, nurses, community health workers, and assistants, and also, as I showed you, among countries. ECHO is about moving knowledge instead of moving patients. I ask you to join us, and together we will reach our goal of improving 1 billion lives by 2025. Here you have the emails of the two groups, New Mexico and Uruguay. And in a very short summary, ECHO is a movement that demonopolizes medical knowledge and democratizes medical care, especially in underserved areas all across the world. Thank you very much.
Thank you. Our next speaker will be Professor Christian Treppo. He's a professor emeritus from Claude Bernard University and was previously awarded the Career Achievement from EASL, has a long and distinguished career in hepatitis. And today he's going to talk to us about innovation in the clinical realm. Professor Treppo.
Thank you. I'm grateful to the organizing committee to give me the opportunity to present ANRS and how ANRS is, by integrating HBV, is pushing the HBV cure. As you know, HBV is a retrovirus in disguise, and both viruses do replicate by reverse transcription and maintain persistence by integration. So this common biology, and as you all know, the overlapping epidemiology commands for a common strategy. Of course, if we are here today, it's just because of the revolutionary success of HCV cure. And as we all know, this was driven by HIV virological research. And this should fuel the HBV cure. You all recognize Françoise Barré-Sinoussi, Nobel Prize from Pasteur Institute. And as you see, she's a champion of HIV cure. And she stands in the committee of ANRS, and she's pushing for HBV cure as well and giving advice. Of course, ANRS is teaming, started with HIV infectious disease as an independent agency, and then very fast hepatitis as being integrated for obvious reason, and we'll see the benefit of that. Budget, of course, it's a pretty key point. It's just a modest budget of 50 million euros, but hepatitis got 10 million. And as you can see, research in North-South is a key importance for ANRS research and for what we are talking about. The goals of ANRS are very clear. Push HIV and HBV cure both at the same time. Promote test and treat strategy, and also access to care, better care for all these viruses infection. And we have a major concern about North-South and socioeconomical impacts. This is the timeline. You can see 2008 when it all started, HIV cure, and then hepatitis cure is in green, started in 2014. And very soon there was a joint venture between France and Germany, infectious research activities, and this is going further. Now, in the same way that HIV has become global, international with IAS, HBV is doing the same with an acronym ICE, and I know you know it. It's International Coalition for Eradication of Hepatitis B. Now, what is ANRS doing? There is a special group, AC34, and it's chaired by my close colleague Fabien Zoulim, and it organizes annual international workshops, twice a year meetings, network, consortium of liver humanized mouse and other models, and cohorts. And of course, cohorts, as you know, is very important for the success of ANRS has been pretty much based, and we'll go further through the cohort. And for hepatitis, we have a cirrhosis cohort, we have a transplantation cohort, and we have a large treatment cohort. As you can see, we have already 12,000 cases of HCV and over 6,000 of HBV and co-infection. So it's also an international program. As I mentioned already, we have a team for both HIV, HBV with Germany, and Germany is actually very productive in the field of HBV with fantastic breakthroughs coming up. And ICE is going on, and they are representative in this room, and this is an important move for globalization and speed, because it all goes by speed. This is just the curve of increased funding through INRS for HBV. And an example of the benefit of this cohort is the story, the controversy you heard that the DAAs would increase liver cancer. And of course, there was a Spanish group, famous liver cancer Spanish group, then an Italian group that published in the, and when ANRS revisited these claims, which were very embarrassing and counterproductive for patient care, the answer is very simple in this gastroenterology paper this year. It's just a coincidence, you know, statistical bias. So this is the benefit of this large immediate benefit of these studies. Now, this is just not to confuse you, but to raise hope. This is the future direction. We have identified many new targets for HBV. So this is, sorry. So we have a new target. It went a little bit, this is it. And we have antivirals on the right. I don't go into the details. And on the left, you have immune modulators. And then we have the checkpoint inhibitors revolution coming up. So there are over 50 drugs in the pipeline. They can only succeed. They can only succeed. So we are not dreaming. We are just on the path. And what we do actually in therapy, we just clear HBV DNA. So we freeze the progression, but not the cancer. And it was emphasized that there was not enough talk about cancer. And of course, it's a major, major concern for ANRS. What we wish to achieve is to clear S, and that would equate to natural recovery. And the question is, are we going to use only the many antivirals on several targets for like HCV strategy, or we will have to add up something more, immune reactivity. And this proof of concept of combining antivirals together with some modulators, but interferon is one of them, and it does the job. Interferon acts as a booster. There was a presentation last week in ASLD showing the proof of concept. So yes, we can, yes, we will. And this will be achievable within the frame of the elimination. And hopefully HBV may be front runner. Thank you very much.
Thank you. Now we'll switch gears and turn to our innovation panel. We put out an open call for innovations, as Michael described, and we were delighted to receive a wide range of submissions, and a few of the finalists are presenting here today. But first, I'd like to start with the Sao Paulo Challenge. And if you could go to the next slide. So Carnival is the local participatory activity. People-powered, creative, community-focused, and the Sambadrome in Sao Paulo, if you go to the next slide, what I'd like you to do is each of you to guess the length in meters of the Sambadrome in Sao Paulo. The Sambadrome is during Carnival. This is where all the floats go through. Don't talk to your neighbor. Don't consult your phone. For those of you who have computers in front of you, don't look at the computer. Get a piece of paper, write down your guess in meters. And then at the end, we'll collect all of these guesses, or actually in a couple of minutes, we'll collect all of these guesses and see how the group did. So, this is, Okay. So we'll write down your guesses and we'll collect these in just a few minutes and get going. So in terms of the innovation panel, our first speaker is Emily Curio. She is the Director of Federal and State Affairs for Project Inform, an organization working to end HIV and hepatitis C epidemics through advocacy and education. She's responsible for the organization's national and California-based Hep C policy activities, and she chairs the California Hepatitis Alliance. So, Emily.
Good afternoon. Thank you very much. I'm very pleased to be here on behalf of End Hep CSF to talk about our work to eliminate hepatitis C in San Francisco, California, in the United States. And we're doing that by prioritizing the engagement and treatment of the most marginalized and stigmatized people affected by the virus. And I also just want to say it's a pleasure to be on this panel with all very intelligent women, so I'm excited about that. So these are some photographs from our launch day, which was World Hepatitis Day 2016. And we had been laying the foundation for about a year prior, but we had a formal launch at San Francisco City Hall with speakers from the local health department and other experts in the field, as well as people affected by hepatitis C. These are our partners. We're a multi-sector collective impact initiative. So we're a partnership of 32 organizations, and we have over 100 individuals who participate in some form or fashion. The fact that this is a decentralized initiative and people-powered is critical to our work and to reach people who are at risk for and living with hepatitis C in a variety of settings, both within and beyond the walls of clinics. And our partners work providing harm reduction services, testing, and treatment in a variety of settings. And that includes primary care services, drug treatment programs, syringe access programs, programs serving the homeless and marginally housed. And we have a very strong shared message that new treatments have changed the game. And we really believe we have the tools to eliminate hepatitis C in San Francisco. As we're world famous for, we have a strong HIV infrastructure, we have a strong drug user health infrastructure, and we've been able to incorporate hepatitis C into these on a shoestring budget with our focus on integration. The partners and participants in NHEP-CSF have come together with a shared vision and a mission and a strong focus on the communities most disproportionately impacted. And we've come to realize that the NHEP-CSF initiative in and of itself is an intervention, that having a formal framework, a statement about eliminating hepatitis C, has strengthened people's commitment to addressing Hep C within their organizations, and the initiative helps to ensure that our efforts are complementary and not duplicative. This image gives a sense of how we're structured and how we leverage our partners' expertise and make use of people's time efficiently. The coordinating committee in the middle handles our big decisions, how to spend our money, what our mission and vision should be, how to commute our message to large audiences like all of you. The high-level advisory groups, the executive advisory committee, and our community advocates meet only a few times a year to inform our strategies. And an example of that is we just held a community meeting on August 3rd and got feedback from community members who might not be in a position to participate regularly, but were able to tell us about their lived experience being at risk for and living with hepatitis C, and we were able to share information with them. And then we have topical work groups, research and surveillance, prevention of infection and reinfection, testing and linkage, and treatment access, and they engage in specific activities, and I'm going to talk about one that the research and surveillance group did next. So the researchers and epidemiologists in our initiative just developed our first Hep C prevalence estimate, and I'm not going to get deep into this, but just want to make the note that this is really exciting for us because we've never had any very informed estimate of how many people are living with hepatitis C in San Francisco. So this really gives us a baseline to measure our success. In 2014, when the new generation DAAs came to market, few providers in San Francisco were treating hepatitis C in primary care. And those doing so were working in very high prevalence clinics. They were extremely busy because they were the only ones doing it. So we've done a lot of work to make sure our safety net clinics, those clinics serving the most marginalized and stigmatized in our communities, have primary care providers who can treat hepatitis C. And primary care providers who are skilled in addressing substance use and mental health issues and homelessness are critical for reaching many people living with hepatitis C who would not otherwise be able to access specialty care for hepatitis C. Treating hep C in primary care is optimal for most people with hep C, and it opens the door to engagement in a variety of other health and social services. But that said, we found that some people are best reached in places where they're already engaged. And so we've gotten really creative, and we've reached into places like methadone clinics, syringe access programs, on the street and in the county jail to provide treatment in non-traditional settings. And supporting people in this way takes significant effort. The care cascade is difficult to wade through for many people, and we need more resources to scale these services. Here's some preliminary numbers about our work providing treatment in a variety of settings, and this really reflects us just getting started. So again, we only launched in 2016. We estimate that we've treated already about 25% of the viremic individuals since the DAAs came to market, and that's probably an underestimate. And of those, we conservatively estimate that 300 are people who inject drugs. So our hope is that we're treating the right people, and the people we're treating are outpacing new infections and slowing transmission, so that we're working toward our goal of elimination. We firmly believe that everyone living with hepatitis C deserves access to curative therapy. And in the US, when the DAAs came to market, there were considerable issues. Many public and private payers implemented cost containment measures and limited access, particularly for people who use drugs. In California, where San Francisco is located, our public health insurance system has relatively liberal access policies, but the process of getting medication is still laborious. So when people who are marginalized and stigmatized are able to access treatment, it improves their quality of life. Our primary care providers are talking about people wanting to engage in diabetes care, drug treatment, stop smoking, take their statins because of the empowerment of being cured of hepatitis C. I want to acknowledge the members of our coordinating committee. This really emphasizes the depth and breadth of our collaboration and the multi-sector commitment to our shared vision. And we really believe that working together, we can eliminate hepatitis C, much as we made the dinosaurs extinct. I have one more thing. I want to thank those of you in the room who've had hepatitis C and have talked about your experience of being cured. It's an inspiration, and that's what helps motivate people who would otherwise not be motivated to seek treatment, is to hear from their peers. So I really want to thank you. Lost my last slide. Well, I wanted to show you there a photograph of San Francisco City Hall on World Hepatitis Day, illuminated in jade for hepatitis B and red and yellow for hepatitis C. And just let you know, if you have questions, if you want to reach out, our website has a lot of information, and you can reach out to me or one of my colleagues. And thank you so much.
Thank you. Our next panelist is Anila Goswami. She comes from the Institute of Liver and Biliary Sciences, where she's been a hepatitis nurse coordinator for the past 7 years. So she's really on the front lines. When there are side effects, when there are problems in the clinic, they call Anila. And she also coordinates training programs, and today she's going to talk to us about the role of the nurse in comprehensive hepatitis services.
Thank you very much. My name is Anila. I am a hepatitis nurse coordinator at Institute of Liver and Biliary Sciences, New Delhi, India. It was 8 years back. I've joined my institute as a clinical nurse. In the initial 3 months, I have worked in the inpatient department. It was interferon era. There, my hepatologist, Professor Serene, felt that there is a need of a nurse who can initiate, counsel, and monitor the hepatitis C treatment. And then thereafter, I have joined him in the outpatient department as a hepatitis nurse coordinator. There have started my journey. I've monitored more than 1,500 patients who have received either peg interferon, ribavirin, or direct-acting antiviral therapy. The patient populations were chronic hepatitis C patients, and chronic liver disease, decompensated and compensated with associated with hepatitis C. While India leads the world in providing DA at lower cost, there is very limited trained manpower to counsel, initiate, and monitor the therapy. HNC model is an effective way of improving the clinical outcomes of hepatitis C patients. How HNC is different? Is she different from a hepatitis nurse practitioner? Is she different from any other nurse? Yes, she is. She should have some communication skills so that she can educate the patients and their families about the hepatitis C and their treatment. She should have good counseling skills so that she can educate the family with emotional support and advocacy. She should have good networking capacity with other disciplines so that patient can have better care and management. She is the link between the clinician and the patient. Let's say, like if a patient starts with the therapy and he has to have 300 contacts with the clinician cannot give time to the patient. Out of the 300 contacts, the patient contacts the clinician only 4 or 5 times. The rest of the contact points are made at hepatitis nurse coordinator. She bridges the gap between the patient and the clinician. She liaisons with the patients and the multidisciplinary team for effective care and management also. HNC model is a networking. It has got 2 components. The first one is a 3-tier counseling model. The other one is a multidisciplinary teamwork. The 3-tier counseling model involves a hepatologist who diagnoses and prescribes the treatment. Then the patient goes to the epidemiologist who educates about the disease transmission and prevention. Then the patient goes to the hepatitis nurse coordinator. There she initiates the treatment, then monitors the therapy, educates the patient about the side effects, how to cope up with the patient, how to be adherent with the treatment. Then she links the patient to a phlebotomist. There he gives a checklist of the investigation which has to be done weekly or monthly according to the prescription. Thereafter, patient goes to the pharmacist where he issues the medicines and counsels the patient about how many tablets has to be taken and what is the dose of the treatment. Both the 3-tier counseling and the multidisciplinary teamwork reinforces the treatment adherence and effective patient care and management. As a hepatitis C nurse coordinator, I have some specific functions to do. The moment the hepatologist prescribes the medication, I will have to put the patients on regular protocol-based monitoring. The patient starts coming to me, like before she or she meets the hepatologist, I take a history. The past history is being taken. Patient's baseline investigation data is recorded. Further, I educate the patient on the treatment, whether this would be a 3 months duration, whether it would be a 24 weeks duration, and the side effects are well informed to the patients. I do a weekly monitoring of all the investigations like complete blood count, liver function test, creatinine, etc. And it is recorded in the patient, and it is updated every week, and it is given to the patient on every visit. I do reinforce the need of treatment adherence and follow-up visits. Patients are well informed that what will happen if they miss a pill, if they stop the treatment without the order of the physician. And they are advised to have follow-up visits. The follow-up dates are prescribed in the prescription sheet itself. Since the patients are well informed about the side effects, they report to me as soon as possible when they observe something. The side effects management is done in consultation with the hepatologist only. Like in the interferon era, the patient used to have anemia. Then at that time what happened, they used to send me the reports on email or telephonically. I used to advise them. And even for the reduction of ribavirin, I used to consult with the hepatologist before advising the patient. 24/7 telephonic advice and support was given through the whole treatment. In the interferon era, I used to get calls in the midnight also, but along with the direct-acting antiviral therapy, the side effects are less now and patients are well treated now. The hepatitis nurse coordinator model has done an impact in the treatment or adherence and patient satisfaction and increased disease awareness. With the regular protocol-based monitoring, the treatment adherence has improved. Patients know what will happen if they miss a pill. They will know they will have relapse, they will have breakthroughs, and they will be a non-responder. So they're well aware, they will never miss the tablet. They're very adherent to the treatment. Improved patient satisfaction. Even if I don't have a data, like mine is not a scientific presentation, so I've involved in any data, but there were more than 98% of sustained viral response at week 12. And the patient satisfaction, I even had families, their mother, children, like 4 or 5 children were anti-hepatitis C positive. They all had to undergo the treatment at the same time. It was very difficult for them to manage. With my support and care, they could all get treated, and their all hepatitis C virus is negative now. They have achieved SVR also. They're very happy, and the satisfaction level is high. Also, there is increased disease awareness. With the proper family and patient education and counseling, the patients are well aware about their disease. Even the family, even anyone comes to be positive as hepatitis C positive, the family members, they themselves come forward and get tested themselves for anti-HCV. So just to conclude, I would say nurses go that extra mile to provide comfort, care, and support to the patient. Therefore, hepatitis C nurse coordinator plays a vital role in treatment of hepatitis C and also the elimination of hepatitis C. Last but not the least, I would like to acknowledge my team of ILBS, and thank you very much.
So our next speaker is Lien Tran. Lien is a community education officer and positive speaker at Hepatitis Victoria in Melbourne, Australia. Her focus is on health promotion and health program evaluation, with a particular interest in empowering communities as a way to lead the most helpful and powerful community initiatives. Lien?
Thank you very much. I guess what I'm going to do now is just to tell you my personal stories and our personal stories of moms and dads and children in the family living with hepatitis B, and what we are doing, so we can discuss about that within the family. Did anyone of you think that I looked familiar? If yes, that's exactly my purpose. If you were here early this morning, then I was there in the patient testimonial, the first one in the morning. And that's the reason why I'm wearing this hyper colorful guy. So this is on the left, my 2 daughters are, they're here. Are feeding a wallaby. They still call it kangaroo, but not a big deal. So they are 5 and 3, and they start to ask me questions around body and health. And on the right, myself with my friend Yith and her 5-year-old daughter. So both Yith and I live with hepatitis B. Anyway, because you listened to my story this morning, so now this is about Yith. So she lives in Melbourne with her husband and 2 daughters, 5 and 7. She's from Cambodia. She speaks Khmer, Cambodian language, Cantonese, Vietnamese, but not English. That's the reason why I can talk to her, because I also speak Vietnamese. So I first met her in 2015 and was really moved by her happy story. She suffered seriously from stigma and discrimination against Hep B, with a big part related to her children. So her kids were actually isolated from the communities, and then she didn't know what to tell them. Then the photo that you are looking at was taken earlier this year when I came to visit her at her house in Richmond and in a suburb of Melbourne to talk about this exact project. Then we are just thinking, my daughters and his daughters, they are growing up and they start to be curious about health, about body, and about themselves in a wider social interaction. And we want to talk about hepatitis B with them, but just we do not know how to do it. Actually, how many people living with Hep B are dads or moms? A lot. Then just like 2 of us, they are struggling how to tell their children about that. So it's just one thing, how. And I think we were really lucky that we have at Hepatitis Victoria, where I work, we have a really brilliant young mom, and she had the same question, but she was really, I think she was better than us, I think. So she came up with an idea, because like, after observing the value of story time to the understanding about life, about different things that she observed in her kid. And that's how we are working on her idea. So what we are doing, we are developing storybook, fiction stories with characters and a conversation, not information book, and animation to help children understand basic information about Hep B and understand what they can help families, their dads, their moms, or even if themselves living with Hep B or their siblings. That's a family business, that Hep B. And let's see our journey. So like after that was proposed, I was hired as a project coordinator to coordinate all the activities of the program. And the first thing we did was to establish a community advisory group of people with lived experience of Hep B. So we came together, and at our very first meeting, we discussed about what we want the storyboard is, what content we want to include in it, and what is the overall theme or tone of the resources that we are producing, and how we conceptualize it. And our principles were bright, colorful, yes, colorful, positive, and silly. Sure, you are working with children. And then we held art competition for children aged 4 to 12, and to ask them to draw the little happy hero of themselves before they actually draw their hero. We delivered tailored education session for them so they could understand about Hep B and our intention, like our overall tones for the project. And then the submissions from the kid inspire the professional production that we did afterward with our animator, our writer, our professional writer, and illustrator. And just a note, the resource will be translated in a number of different languages, especially the language spoken by higher prevalence community. And after those were finalized and surely approved by the advisory group, it will be available free online, and the hard copies will be available at community organizations, at local libraries, and to be honest, anywhere that our advisory group wanted them to be. So we can see in all the implementation part, the people with lived experience are there. And what else? There's another thing. So there's one thing that we have been doing the whole time that we are doing the project. We are running a crowdfunding project to partly fund what we want to do. We want to increase the number of copies that we can produce. We want to translate it into more languages, for example. Then I think it's time for some photo. So this is actually our latest advisory group meeting in August this year. So we are a group of 9 and 10, including me, with different roles in the family. So we have dads, moms, son, daughter. We come from 6 different cultural backgrounds. So we have Australian, Chinese, Vietnamese, Somalia, Cambodia, and Romania. And let's look at some of our heroes. So this is a mom from Somalia. This is a representation of an 8-year-old son. This is a Vietnamese dad and myself, Vietnamese mom. This is a Romania mom, and this is a Chinese Australian daughter. And this is the, at the bottom, you can see that's the session, the education session that we did before, during the art competition, before the kids actually made their innovation, I think. And those are also, they are some of the submission that the kids did send to us. And these were like sent to our illustrator and animator. So to inspire her in the way to create the characters that I will show you in a second. And this is our crowdfunding project. We have not reached our target yet, and you are welcome to visit us and support us if you like. That's the address, and if you want us, you can look at the poster 42A, and this is how our book starts. So it's a normal story. So it's like, Mom and I are going next door to visit Rosa. Sam says, can I come too? Dad say, I hope she's been cooking again. And you can see here, that's I character and Sam. Then just like for the final thing, so what we have been doing as a community, as an affected community, we proposed a project, we conceptualized it, we implemented it, and we partly funded it. And then it's just simple like, so we hope that by doing such a project, we demonstrated our, as affected community, our proactivity and our ability to deliver the project that are helpful for ourselves. And I think I would like to, I may not need to repeat the message again. So as other people also say, nothing, I forgot it. No decision about it without us. Thank you.
Our next speaker is Dr. Amal Megwali, Professor of Public Health and World Hepatitis Alliance Regional Board Member for the Eastern Mediterranean region. She has been at the forefront in promoting behavioral change through community-based approach, and today she's presenting her experience in the Village Free from Hepatitis project.
Thank you. I don't know whether it's working or not. They told me that they are going to work it. Okay, do you hear me now? Okay. Before I'm going to provide you with our story, I'd like to turn light on because I'm not going to present any slides and I'm going to talk from my heart about our experience. I'm talking on behalf of our Liver Patient Association or Liver Patient Foundation. And before also expressing this, I'd like to highlight some issues related to Egypt. As you all know, that in spite of whole activities that were done in Egypt, and from 2008 till 2015, and the reduction that would happen, actually Egypt is still to have one of the countries that are endemic for hepatitis C. And as all of you know, that we have political commitment, we have presidential support for elimination of hepatitis by 2030. And we have now strategy, we have action plan, we have testing, we have diagnosis, we have treatment. But do you think with all of this, is enough for having elimination by 2030? I'd like all of you to think about it, but not to give me any answer. Before, I'd like to express our initiative. Our initiative is unique because we go to the people, we go to the community. We are not waiting for people to come to us to have tested or diagnosed or to have treatment. The second thing that we are unique for is that it is by civil society and led by community and sustained by community. The third stress that actually I'd like to tell you about, which is considered to be very strength, is that we used many public health approaches in order to achieve the elimination within these villages. We used the 4 Ps for the social mobilization. but we use it as social mobilization for health. And at the same time, we use communication for behavior change. We are not working on the level of awareness, but we are working on level of changing behavior. And at the same time, we are working for empowering people by knowledge and by capacity building in order to lead, in order to create demand, in order to ask for their rights. And let me discuss with you the mobilization that we did with the 4 Ps. The first P is concerned with the product. The product is to be tested, to be treated, and at the same time, for those who don't have, to be protected. So the second P was the promotion. How we promoted for this? We promoted for this by culture-sensitive messages that were drawn out of the community. For those who have the disease, we stress upon why you should be treated. You should be treated for not to be get alienated, for not to be to feel stigmatized, for not to lose your job, and this is the situation. But for those who to protect themselves, how their life will be in happy and they will be more strong for having healthy life later on. And at the same time, we target different kind. We target all population within our villages. We target from children from 12 years and above. We target healthy people. We target diseased ones. We target risky population. We target the barbers. We target hairdressers. We target the traditional birth attendants, which were widespread in the villages. And we target also the health professionals. And the third P, which was very important and a challenging one, is a price. And you know that in spite of all pricing that we went through and how cheap the drugs in Egypt, still for the villagers, it's considered to be expensive for them. So we went to the charity approach, in which we have one rich man can take care of a poor man, which is out of our Islamic religion as zakat. But we can use it. It's a way of donation. And the majority of communities working and having associations with charity can do it. And the final P is a place where they got tested, where to have treatment. Actually, they are the one who choose this. And for the majority of our villages, we had the community-based clinics. And for other, they go to the rural health units. And all of this is by the community themselves. After we did our model, we did surveillance for them. How? We tested all negative people after treating all positive, and we tested also the positive ones with PCR and the negative ones with the rapid tests. And we created powerful group from the volunteers that taking care for behavior change and for the messages, because we used culture-sensitive messages in the form of 9 cartoons, which are amazing cartoons, and we use songs, and they are still using this. And we started by one village, and now we reached to 37 villages in order to, and we are going to scale this and extend this and extend our activities. Actually, I think that the take-home messages, we should know government alone is not going, this is not enough, is with only with the involvement of civil society we can achieve our goals. And actually, we have to use many of the public health approaches. The approach used should be out of the people themselves and not to be hierarchy from up to down. No, it should be from the people. We should have the messages that are culture sensitive ones. And I think by this, we can achieve elimination by 2030. Thanks a lot.
Our next speaker is Dr. Freke Zure from Amsterdam, where she works at the Department of Infectious Diseases Research and Prevention in the Public Health Service. So her presentation today will focus on an innovative way of improving access to hepatitis C testing in men who have sex with men community in Amsterdam.
Thank you. I'd first like to thank the organizers for inviting me to present our project, which is indeed about home-based hepatitis C RNA testing for MSM as part of an integrated approach to eliminate hepatitis C from the MSM community. So, here you can see some reports of sexual transmission of hepatitis C among HIV-positive MSM in the Netherlands. And there's been an expanding epidemic since 2000. And of course, it doesn't only occur in Amsterdam. As you can see here, these are European data from the Eurocohort collaborative. And you see a rising incidence since 1996 up to 2014, about 20 per 1,000 person years. So for those of you who are not really familiar with hepatitis C as a sexually transmitted infection among MSM, the next slide shows you some of the risk factors, risk behaviors that are involved in acquiring hepatitis C in this population. And it may be a little bit explicit, but I think it gives a really clear picture of what we're talking about. So it's about condomless anal sex, it's about rough sexual techniques, fisting, sharing of sex toys, and use of chems, drugs before and during sex, including injection drug use, but also snorting of drugs. So besides the rising incidence, there's an alarmingly high reinfection incidence in this population, as you can see here. And if you look at the 2-year cumulative rate, you see that a quarter to a third of all men who resolve their infection acquire hepatitis C again within 2 years. So we believe that these data really show the need for innovative approaches to increase testing, treatment, but also to reduce risk behavior in this population. So inspired by all the work that has been done for HIV in Amsterdam, we started the MC-Free project. It's the Amsterdam MSM Hepatitis C-Free project, and it's a multi-level approach to fight the hepatitis C epidemic. So as you can see here in the colors, there are the different levels that we identified and that we try to intervene. So for example, the individual level, the community level, the health professional level, but also the context itself in which the risk behavior takes place. So testing is one element within MC-Free, and you may think, well, it's predominantly HIV-positive MSM, and in the Netherlands, the majority of them are in HIV care, so they have access to testing and treatment, which of course is true. However, testing within HIV care in the Netherlands is usually being done by hepatitis C antibody testing once a year and ALT tests twice a year. So especially considering the really long time to hepatitis C antibody seroconversion in HIV-positive persons, this testing algorithm is not sufficient to early identify acute infections, treat persons to stop onwards transmission. So therefore we designed a home-based hepatitis C RNA testing service that really allows men to take control, to test whenever they want, wherever they want, in the convenience of their own home, confidentially, without having to discuss risk behavior with a physician. So how do men access the testing service? Well, we developed a website, it's called No More C, and it contains all sorts of information about hepatitis C risk reduction, but also about home testing. And First, men are linked to an online risk assessment questionnaire. Well, the questionnaire really contains 6 risk factors that are listed here, and the aim is to identify whether or not men are at increased risk of acute hepatitis C infection. So this questionnaire was validated previously in a previous study of my colleague among HIV-positive MSM, using data from the Netherlands, but also from other countries. And based on the questionnaire, the answers, people get a personalized advice on whether or not additional testing is indicated. So then persons can purchase our hepatitis C testing kit, which is a DBS, a dry blood spot testing kit, as you can see here. So it's being sent to their home address. They can just take their own sample using our instructions. They send a card to the laboratory of the Academic Medical Center in Amsterdam and obtain the test results within a week via the project website. So men who test positive are then immediately referred for confirmation testing, either at the HIV clinic or at the STI outpatient clinic of the Public Health Service in Amsterdam. Well, testing is, as I said, it's just one element of MC3. I think we all acknowledge that testing and treatment is important, but behavioral interventions are important as well to reach elimination. And here you see some examples of what we are offering online and offline to the MSM community. And the slogan that we have is "See what you can do," to really make it so men can choose acceptable ways for them to reduce their risk for hepatitis C. Of course, we cannot do this without community involvement. And here you can see 4 men. They are from the Amsterdam MSM community, and they were affected by hepatitis C themselves. And they're really willing to collaborate with us, to share their stories, to share their pictures, to really increase awareness within the community and make this a success to fight the epidemic. And these are only 4 men, but we have many more working together with us. This is Dijs. He's from the Netherlands, and I would just like to show you a very short video clip of him.
My name is Dijs Franse, and I'm a Dutch nurse from Amsterdam, and also obviously gay. It's important for me. I think it's important that there is another big focus on hepatitis C at the moment, because there was a lot of focus on HIV the past years and years. But hepatitis C is also a very serious STD, which also need to be controlled and treated.
And I think what he says here, the parallel with HIV is important, because of course in the HIV field we have achieved so many accomplishments in the last years, including self-testing for HIV, but also the biomedical interventions. And I think we should really take this expertise and apply it in the hepatitis field as well. So the next slide shows some of the organizations that are involved in the MC3 Collaborative, and the main partners are the Academic Medical Center of Amsterdam, the Departments of Virology and Infectious Diseases, the Public Health Service of Amsterdam, and STI/AIDS Netherlands, which is an NGO specialized in sexual health. Next slide shows you the pictures of persons behind these organizations. So this is our project team. I really like to acknowledge my colleagues, and of course the community members involved, and last but not least our funders, which are listed here. And thank you for your attention.
Thank you. Our final panelist today is Momo Iwamoto. Dr. Iwamoto is a physician turned field epidemiologist working for Epicenter MSF. She spent the last 18 months in Cambodia, where she's supporting the setup and implementation of the MSF HCV project in Phnom Penh. Today, she's going to talk about using data to improve the quality of hepatitis services. Dr. Iwamoto.
First, I'd like to thank ASLD for the scholarship. I would not have been able to afford staying at Sheraton myself. Okay. I'd like to start this talk with a hypothetical situation. Imagine you work for an NGO and you have a plan to run an HCV program in a country where 250,000 patients are estimated to be infected. And your aim is to bring HCV care to patients living in rural areas. Under maximum efficiency, your program has the capacity to treat 25,000 patients. Your patients are poor and will most likely not have access to any HCV or liver-related care if you do not provide one for them. And in this program, you need to decide which services you would provide. But each service you include comes with a cost, and it's the opportunity cost of not being able to treat another patient. So, if you were running this program, would you screen patients for cancer? Would you stage patients? Would you try to identify patients with varices? Wait, I'm sure most of you have a lot to say about these questions, but hold your thoughts. I want to put these questions into perspective. Let me explain to you what happened in our program in Cambodia. Nearly 1 year ago, we launched a pilot HCV program inside a 250-bed national hospital in Phnom Penh aimed at identifying a feasible care model that could be replicated across health facilities in Cambodia. And this graph shows our patient visits. The yellow bar is a new patient, and the green bar is a returning patient. So we started off slowly with under 50 visits a day with our 4 doctors. And then after 1 month, this happened. The gray bar shows the number of new patients that came but were waitlisted to have their first visit at our clinic. We were faced with a massive influx of patients, and in 3 months, the waiting list grew to over 3,000. So we were afraid the list was going to keep on growing. The number of patient visits continued to rise, and our doctors were exhausted. But we couldn't increase the HR due to space constraints at the clinic. So we had to figure out a better way to serve our patients faster, but without jeopardizing the quality of care. So this was our care model at the beginning. Here we go. It's a bit of a simpler version of EASL, but contains thorough workup of patients and allows us to provide services for some cirrhosis complications. The patients had to make nearly 16 visits to reach cure, and by the end, they were quite exhausted. We were quite exhausted, so we had to simplify. In order to simplify, we ran several operational research studies. We first demonstrated the effectiveness of sulfosylphur decladisvir on genotype 6, which is one of the major genotypes in Cambodia, to show that the regimen could be used pangenotypically. We also ran 2 diagnosis studies, one to test the performance of GeneXpert viral load at point of care among genotype 6 patients, and 2 to test the use of capillary blood for SD BioLine rapid diagnosis test. And through these studies, the diagnosis processes were simplified, and we no longer had to ship blood samples to a centralized laboratory or to foreign countries for genotyping, and screening diagnosis visits were condensed into 1 day. The cost of HCV-related testing also decreased from $270 to $35 per patient. Operationally, we separated out the screening services from treatment clinic to allow efficient flow of patients. We task-shifted consultation visits and fibroscans to nurses and pharmacists to allow doctors to focus on more difficult patients and in initiating treatment. We adapted our criteria for endoscopy and cancer screening to simplify the algorithm for assessing patients prior to treatment initiation based on our patient population data. So through these changes, our care model was simplified from this original full model to the current reduced model. And as a consequence, treatment initiations nearly quadrupled with the same number of doctors. Waiting time between screening and treatment initiation decreased from 4 months to 1 month. And even after simplifying our care, retention of patients from screening to OPD continued to remain high. Treatment completion rate also remained high at 99%, showing good drug tolerance. The occurrence of serious adverse events has remained very low. And the intention to treat cure rate remains above 95%, even when over 80% of the patients that we treat are F3 and F4. So as a consequence of simplification, one medical team was able to screen, diagnose, and initiate treatments for this many patients in nearly 1 year. So what's next? Our next step is to take the simplification process even further so we can expedite treatment for even more patients. We want to diagnose and initiate treatment to patients on the same day. But for now, we still fibroscan patients, screen patients for cancer, provide endoscopy services, and refer patients to palliative care. We still do lab tests for kidney function and child pre-classification. But now we are asking ourselves, but should we continue these things? Do they truly impact the prognosis of patients if we cannot follow through with the management of their cirrhosis or cancer for years? So now I'd like to go back to the hypothetical NGO situation. If you were the implementer of this program, would you screen patients for HCC? Please raise your hand if you would. Thank you. How many of you would stage patients? With staging, you can prioritize treatment, you can separate out the cirrhosis patients easily. Okay, thank you. How many of you would try to provide endoscopy services? Thank you. Okay. So, what if I say that by including all these services, your team would need to provide roughly 5,000 ultrasounds, 2,500 endoscopy procedures next year, and as a consequence, your team's capacity to treat patients decreases from 25,000 to 5,000 patients. But in return, you will provide 1,250 ligatures, which might be life-saving, and diagnose 300 cancers. But you'd still miss detecting another 300 cancer patients, and varices will likely re-rupture if no proper follow-up is done. And what if I say that by including these services, you actually didn't increase the total life years saved, but managed to reduce it by a third? And what if I say that by including these services, you actually end up treating less number of cirrhotic patients for HCV? Now would your answers change? And I use this example to illustrate this point that every decision has a consequence, and every decision comes with a cost. In HCV, I think the greatest opportunity cost of focusing our efforts in trying to expedite treatment is the care we forego for patients requiring long-term cirrhosis management and cancer care. But the reverse is also true, and the lessons we learned was that cirrhosis management is very resource intensive, far more than we had expected when we launched the program, with very unclear evidence that it reduces mortality in resource-limited contexts. The diagnosis of cancer comes at a great cost for impoverished families as they try desperately to find any means of cure, often ending themselves in huge financial debt. For the program, the capacity to treat the HCV infection slows down tremendously to the point that we end up saving less lives. In resource-limited contexts, simplification may be the only way we can deliver cure to the large number of very poor patients who are infected with HCV today. We don't want to waste any more time. The faster we can deliver the cure, the better. And we know from experience that we can provide quality services to a large volume of patients by simplifying the care as much as possible. And of course, we want to do everything we can for our patients. But the sobering reality is that by diverting our efforts to provide cirrhosis management, we actually sacrifice the opportunity to treat a very large volume of patients and to save more lives. So what should be the balance between the clinical approach and the public health approach? So we haven't done the very, very simplified model yet, and I'm here to ask your opinion. So please feel free to email me. Thank you.
Thank you. So we've heard some really fantastic presentations from the panelists today, and this is I think, a testament to the power of local communities and groups implementing. To go back to our Sambodrome challenge, so the actual length was 700 meters of the one that was shown, and the median was 750, so not bad. And the other themes, I think it demonstrates the power of groups, the power of communities, and So I'd like to thank the World Hepatitis Alliance and the WHO for their support, and again, thank all of our panelists for their exceptional presentations. Thank you. So this concludes our session, and the next session will be the closing session.